All right, welcome to our final explainer in this series. This is where we pull it all together. We're going to build a single, powerful clinical model that really connects every single piece of the vestibular system. We're talking from the nitty-gritty physics of the inner ear all the way up to the patient's perception in their cortex. Honestly, this is the framework that's going to help you solve those really challenging cases.
So here's the game plan. We're going to move through 5 key areas. First, we'll lay down a unified framework. Then we'll map out the entire system blueprint. From there, it's all about practical application. How to translate that map directly into rehab, how to use it to decode those tricky mystery cases, and we'll wrap up with the biggest clinical takeaways you need to know.
Okay, let's dive right into this unified framework. So what's the whole point of this model? It's really simple. To draw a straight line from the symptoms you see in your patient right to the underlying physiological mechanism. Because think about it, once you've nailed the mechanism, you know exactly which test to use and which treatment is going to work.
Yeah, the core idea here is to really shift our thinking. Let's stop just making a list of symptoms and start thinking in layers. What we're after is a functional model that helps us pinpoint precisely where the system is failing. That way, we can intervene with surgical precision instead of, just throwing treatments at the surface level signs.
All right, next up, let's build that system blueprint. The best way to think about this is like a stack of computational layers, one on top of the other. We're literally going to follow the signal on its journey as it gets processed and transformed at every single stage.
So this really gets to the heart of it, right? How does a simple head movement turn into a perception, a reflex, and even a memory of where we are in space? Well, the absolute key, is to trace that signal's journey through this computational hierarchy. You'll see that at each level, the information is processed, it's refined, and it builds from this raw head motion data into our incredibly complex perception of space.
You can really break the whole system down into these 8 distinct layers of computation. It kicks off with peripheral mechanics. We're talking pure physics in the inner ear. Then, at the transduction layer, that mechanical force gets turned into a neural signal. That signal is then encoded by the afferent nerves, and then it gets integrated with all our other senses in the brainstem. From there, it drives our reflex outputs, which, by the way, are constantly being fine-tuned by cerebellar prediction, before finally being perceived by the thalamocortical networks. It's an incredible journey.
And here it is, the whole shebang, the complete system map. We're going to take a really high-speed tour, but don't worry. For each layer, we're just going to focus on the single most important clinical concept, the one handle that you really need to get a grip on.
Okay, let's zoom in on the transduction layer. The really crucial thing to get here is the difference between type 1 and type 2 hair cells. Just look at the table. Type 1 cells, they are all about speed. They're handling those super fast, high-frequency head movements you need for a crystal clear VOR. Now, type 2 cells are the opposite. They're built for stability. They're feeding the brain steady, graded signals for posture. This whole duality, this speed versus stability thing, is a fundamental design principle of the entire system. It's brilliant.
Okay, moving on up to the central processors, the brainstem and the cerebellum. Now, the vestibular nuclei, they're not just some simple relay station. No way. Think of them as the first major hub for mixing vestibular info with vision and proprioception. They're also home to the velocity storage mechanism. That's the cool trick that lets us feel motion even after the canals have stopped firing. And the cerebellum, it's like the ultimate predictive controller, always fine-tuning our movements. The flocculus, for example, is constantly calibrating the VOR, while the nodulus and uvula tackle the really tricky job of telling the brain whether you're just tilting your head or actually moving sideways. So clever.
All right, so we've got our blueprint. Now for the really practical part. How do we turn all this incredible knowledge into a tool we can actually use in the clinic?
This is it. This is where the rubber meets the road. We're going to connect the dots from this deep physiology right to clinical action. The big question is, how do we go from what the patient is telling us to picking the right test and then pulling the exact right rehab lever?
And this is our translation dashboard. The idea here is beautifully simple. We map the clinical phenotype, the pattern of symptoms you're seeing, directly to the level where the system is failing. And that in turn points you straight to the best test and the most effective rehab strategy. Let's walk through a few examples to see how it works.
Check out the logic here. It's so clean. So say a patient comes in with acute vertigo and an abnormal V-hit. Boom. That phenotype points you straight to a peripheral canal failure. So what's your rehab lever? Adaptation. Simple. Now, what about a patient with an ocular tilt reaction?
That phenotype is screaming that there's a problem with the otolith or the graviceptive pathways. So the rehab lever is totally different, verticality retraining. And then let's take a third case, someone with visually triggered dizziness, but all their peripheral tests are normal. See, the failure here is higher up. It's probably a cortical network issue, which means the rehab lever is different yet again, habituation. It's so important to remember. The mechanism always dictates the therapy.
Okay, but what about those patients that just leave you scratching your head? You know the ones. All the peripheral tests, VHID, VAMPs, they all come back squeaky clean, but your patient is still incredibly dizzy. What do you do? Where do you even look next?
This is where our framework is such a game changer. It helps us completely reframe these so-called mystery cases. We have to start asking a different question. What if the sensors are working perfectly, but the central computation is what's failing? Suddenly, the problem isn't in the labyrinth at all, it's somewhere higher up the chain. And this illustrates those potential failure points perfectly. A normal VHIAT is great, but all it does is clear level 1, the peripheral sensor. That's it. The problem could still be in the coding, or the brainstem integration, or cerebellar prediction. You get the idea. Our framework gives you this logical ladder to climb as you investigate these really complex cases.
Okay, let's wrap this up and bring it all home. I want to leave you with the 3 most important takeaways from this model, things you can literally apply in your practice tomorrow.
First, and this is a big one, stop thinking of the vestibular system as just a simple reflex arc. It is so much more. It's a sophisticated, multi-level inference system. Second, that mystery dizziness we talked about, more often than not, it's just central dizziness. It's a failure in computation or prediction, not a faulty sensor. And third, and this is probably the most important point of all, rehabilitation is applied neurophysiology. You have got to match the rehab lever to the specific mechanism of failure. Don't just do it out of habit.
So I'll leave you with this question. How is this unified model going to change the way you approach your next complex dizziness case? Because now you have a robust method to localize the lesion, pick the right test, and deliver truly precise, mechanism-based rehabilitation.
Hey, thanks so much for joining me for this. To dive deeper and check out other great resources for clinicians and patients, head on over to AustralianDizzinessClinics.com. And of course, if you found this helpful, please subscribe and leave us a rating. It really helps.